and how heavy internal medicine is. So it's important that the exam that you'll do at the end of your 11 weeks in internal medicine is the only cut in internal medicine you will do. So you really need to step up your game. And hopefully by the end of this session, you'll have an idea of how to take a comprehensive history in internal medicine. So we'll start with the biodata. First impressions matter. They really matter. Because most of the time, if somebody is listening to you, you have to make use of 10 minutes. Because we know from studies that the first 10 minutes is when somebody is actively listening. So everything of importance has to be there within the first 10 minutes. And that's why the biodata is key. You have to have the patient's name. I know these things seem like they are obvious. You have to have the name, you have to have the age, you have to have the gender, you have to have the occupation. And what's not on these slides in terms of the occupation is you have to say how long have they been doing that particular task. For those of you in the rest pod in 7D, you are aware that there are some conditions that are linked to occupation. Yeah, like the pneumoconiosis. So this guy tells you, I've been a painter for maybe 20 years, and he's there in the ward with rest symptoms, and you've not highlighted that. The lecturers listening to you, especially during your exam, they get really upset because you've not highlighted an important fact. You've not told me what does this person do for a living. So you've not painted a critical biodata. So the occupation is important and how long they've been undertaking that particular task. What is another thing of importance is the residence. We really take this one for granted, but if somebody tells you, especially in those guys in the rest pod or those guys in hematology oncology, they tell you, I have been living in X area. Maybe they've been living in Dandora. You're doing community health, so you should be aware that there is a landfill in Dandora. And it's important to know that how long has this guy been living there? Could it be related to these symptoms? Is it infectious? So should we start contact tracing? That's why you need to highlight he has been living here for how long, and other than that, where else did he stay? And would that be important in painting your diagnostic picture? You also need to highlight, obviously, when they were admitted, and do this in terms of duration. I've not highlighted this here, but it is important to say the date of admission, but don't give it as a date, give it as a duration. So say 2 weeks ago, 3 weeks ago, 4 days ago. Don't tell them admitted on the 29th of September 2024. Nobody can start doing that math. So it's either 2 days ago, 1 day ago, and that's how you will talk about your duration of admission. Yeah. Then another important thing that should be in your biodata, some lecturers will say otherwise. Once again, that they're very different they're schools of thought within internal medicine. Everyone has their way of things, and it's important to know that most of them agree that you should have the chronic conditions up in your biodata. So if you find a patient, maybe they'll tell you I'm seropositive, yeah, but then the word in the word, you have to have some decorum, some etiquette befitting of somebody who's handling the sick. So you have to use words that show that you respect the patient. So you can't be shouting, the patient is HIV positive. We say these things as a joke, but for the first couple of weeks, you will be shouting these things and they'll make the patients apprehensive and they won't tell you some things, yeah? So seropositive is the word when it comes to people who are living with HIV. So you can either say the patient is seropositive, or when you're presenting, you could say the patient is living with HIV. So now you've highlighted a chronic condition. So you've said that maybe the patient is seropositive, and you have to find out which medication they're on. So they'll probably tell you something called TLD. That's the regimen we use in Kenya. No TLD, tenofovir, lamivudine, dolutegravir. It's very important. You know what the drugs are, and the first line, maybe the second line and the third line for HIV treatment in Kenya. It's very important. So you say that maybe they're seropositive, they have been on TLD for this amount of time, yeah? They are on follow-up at this clinic or dispensary. What was their last CD4 count? Yeah. Let's say you meet a patient and you have Njoro. Njoro is diabetic. Yeah. So you have to ask Njoro, if they are diabetic, which medication they are on. Yeah. So if they tell you maybe Nico, they'll tell you something like I'm given a drug, I inject myself X amount of times a day. You need to know, is it short acting, is it rapid acting insulin, short acting, intermediate, or long acting insulin? Yeah. If they're telling you it's Napatua, I'm given a drug and I'm swallowing it, is it, you have to highlight, is it metformin or could it be something else? So you need to be you need to dig deep. You need to give them names. The lecturers won't be satisfied in internal medicine if you just say, so my patient is diabetic and one, two, three things, he's been on he's been on medication. They don't like that. You highlight that, you highlight the last time that they went for HbA1c levels. What was the level? What was their random blood sugar? All this should be painted in the biodata, and how do you put it together also matters. Don't start saying, okay, name Joseph Njoroge, age 43. He's a man. He's a painter. He lives in Kawangware, or he resides in Kawangware. No, proper presentation. Once again, just carry yourself with the demeanor of somebody who knows what they're saying. So I'm presenting X and O. He is this age. He lives here. He has been doing this for a living for this amount of time. Do it in continuous prose. And you highlight the chronic condition, as I've said, and you give the date of admission, obviously, in terms of duration, and you highlight the ward that they are in. If you are presenting to the lecturers within the ward, but if you're going to present on exam day, that's another different story. So now we've done the biodata. Before I get to the HPI, there's something of important I have to mention, and that's the presenting complaint. So what makes a good presenting complaint? Number one, all presenting complaints, as much as they tell you or what the patient says in patient's own words, yes, you know, but you must use medical reasoning to interpret what the patient is saying. Or sometimes you will be in the ward and you will meet a patient who is well versed with their condition and they'll tell you, I have dyspnea. You, as a good student who has been told that when the patient says they have dyspnea, when the patient says you give a presenting complaint, or when the doctor says give a presenting complaint, give it in their own words, in the patient's own words. Well, umesema this and this. The patient told me presented with X days of dyspnea. Trust me, you have failed. And as I've said, first impressions matter. They're only listening to you attentively for the first 10 minutes. After that, you're making noise. So 10 minutes, you have to make a proper impression. So for your presenting complaint, majority of the presenting complaints have been highlighted in Hutchison's. Yeah. If you go through your Hutchison textbook, and how to use Hutchison. So you have the first portion of Hutchison's that really extensively talks about the history taking. It's not to be ignored. Don't rush to the exam. Go through that history. You'll discover that maybe in RESP, they'll tell you cough. They'll tell you breathlessness or shortness of breath. They'll tell you chest pain. They'll tell you fever. And if you read within those paragraphs, there are highlighted relevant associations and things that you should pick up in your history related to that. Like you have a patient with a cough. So your presenting complaint will look something like he came in with a cough for 3 days or for 4 days. And then try and keep your presenting complaints to 2 or 3 maximum, 3 maximum, 2 being the minimum. Don't have one presenting complaint as much as possible unless it's loss of consciousness. Once again, as I've said, history taking is an art as well as a science. So you'll realize that different systems, as you go through, different systems have different ways you will take their history. Like, listen to how this sounds. Maybe you have a patient in neuro, in 7B. Patient has lost consciousness. Try and listen to this. So the patient came in with loss of consciousness and vomiting. Number one, came in. Just look at the syntax of what you said. So it doesn't make sense. Came in, you put it in continuous prose. Your biodata has to flow into your presenting complaint, which has to flow into your HPI. All of it has to be in continuous prose. So you'll be like, so-and-so was rushed in after losing consciousness for this period of time. Very important thing to have in your presenting complaint is the issue and the time. And once again, I've said loss of consciousness is special. You will have loss of consciousness on its own, but majority of the time you will have 2 or 3 presenting complaints in most of the wards. Yeah. So now you've done your presenting complaint, you're in your history of presenting complaint. A good HPI requires 6 things. These 6 things is what they're looking for as they listen. Within these 10 minutes, you might mumble, you might fumble, you might say a lot of things, but if you have these 6 things, you've cooked. You have a systematic analysis of symptoms. What does a systematic analysis of symptoms involve? A systematic analysis of symptoms uses Socrates for pain and operates for every other symptom. What does this mean? Don't go around, patient has told you they are dyspneic or they're experiencing shortness of breath, and you're over there trying to tell me sight, or you're trying to say sight. It doesn't make sense. So when you use operates, you have the whole picture for everything else, but Socrates is specific for pain. And once again, with Socrates, the A in Socrates is what I'm getting to in point number 2 is very important, and I'll get to it. But once again, let's just go through it. I hope you guys are aware of what Socrates and operates mean in full, because they're very important to know. Once you're describing, let's say, shortness of breath, how did it start? Yeah. So you've said the onset. How has it progressed? And how do you show progression? You will show progression by saying this. Initially, patient reports experiencing shortness of breath only on exertion. However, 2 days later, patient reports experiencing shortness of breath even at rest. Once again, I'm going to introduce something new. I hope you guys have been going through it, but I know it's still week 2, so it might feel like it's overwhelming. So let's say you're in the rest pod. Njoro tells you he has shortness of breath. Yeah? What we use in the rest pod is Medical Research Council grading of dyspnea. But then let's say you meet Otieno. Otieno is where? Otieno is in the cardiovascular ward in 7C. Otieno tells you he has difficulty in breathing. Note what I've changed. I've told Otieno he has difficulty in breathing. I've told Njoro he has shortness of breath. These two, some like to use it interchangeably, but the physiology of it shows that they're very distinct complaints. Difficulty in breathing, somebody will tell you they'll feel like somebody is sitting on their chest. Yeah? So they can't even expand their lungs. That's what guys in the CVS ward, because of pulmonary edema, that's what they feel. Guys in the rest pod will tell you they have shortness of breath because they feel like they either can't get air in, restriction, or they can't expire, obstruction. Yeah? So that is very important to highlight those. So let's say you've met Njoro in the respiratory ward, has told you, Doc, I experienced shortness of breath on exertion. 2 days later, it was now present at rest. So how will you tell the consultant, maybe Dr. Mecha, how will you tell Dr. Mecha that this is your patient? You'll tell Dr. Mecha that patient reports maybe a sudden onset, shortness of breath. Initially, he reports the shortness of breath was only present on exertion, suggestive of MRC grade 2 or grade 1 dyspnea. However, 2 days later, patient reports shortness of breath even at rest, suggestive of MRC grade 5 dyspnea. I'll tell you why later I use the word suggestive. So you do operates. I hope now you're getting the idea. Then now when you come to Otieno in the cardiovascular ward, sudden onset difficulty in breathing that started initially was only on exertion, suggestive of NYHA grade 1 or grade 2 dyspnea. However, 2 days later was present even at rest, suggestive of NYHA grade 4 dyspnea. So that's how you'll present it. That's how you present it. You make it seem like it's in continuous prose. So you are speaking key points of what's happening to the patient. Yeah, obviously, all of us were aware about the exacerbation, the relieving factors, but they sometimes be serious when you're giving your exacerbation and your relieving factors. Try and see if they make sense, given with the little that you know from your pathology and what you have been reading. Do they make sense to that presenting complaint? Because sometimes the patient could be saying many things and they are not making sense. If the patient tells you the chest pain, doc, was being relieved by medication, try and ask which medication. Did you have to get a prescription for it? Or did you go and buy the medicine over the counter? And if so, which medicine did you get? Somebody with a chest pain or somebody both in the cardiovascular ward and the respiratory ward, they might tell you, I relieved my chest pain with Maramoja. Maramoja is aspirin. Don't write the brand names, write the drug name. So they'll tell you aspirin, Maramoja. Why is that important in RESP? It's important you pick that out because in RESP, there's something called aspirin-induced asthma. In CVS, aspirin, low doses of it are very protective. Doses of aspirin are protective in CVS. So it's very important to highlight what drug they use to relieve their symptoms. If they use drugs, if they just change the position, highlight the position and try and see, does it make sense based on the anatomy that I know? Yeah, obviously for time, it's either intermittent or it's constant. Try and know. There are some people, particularly in the rest pod, they'll tell you, my cough is worse at night. Yeah, my cough is worse at night. Very important thing to highlight. Yeah, some people will tell you, in gastroenterology ward, they'll tell you, my right upper quadrant pain is worse when I eat fatty foods. Very important thing. Some will tell you in the renal ward, if you get some, most of them are in neurology, but you might get one or two that will tell you, my pain in my flank area comes and goes, comes and goes. So very important thing to have. For severity, try and keep it on a scale. Try and keep it on a scale. So you have on a scale of 0 to 10, patient reports the pain being a 5. No, give it a rate. Give it a, try and have the lower interval and the higher interval. Yeah. So try and say that, give it a range. So say maybe 4 to 5. So that's what you'll say. The patient has told you 5, you'll say 4 to 5. 4 when it's okay, 5 when it's bad. So the A, associate with relevant symptoms. Note the word that I've used, relevant. You can say a lot, but it's not relevant. Where you are, you have to ask yourself, what is relevant to this presenting complaint that this guy has told me? So this guy has told me he has a headache. Is there dizziness? That's the next thing I have to ask. Has there been any changes in vision? Any tearing? Any neck stiffness? Any fever? Yeah, very important to associate with relevant symptoms. Once you associate with relevant symptoms, once again, try and keep this thing flowing. If you note why I've put number 2 before number 3 is, you see these A's in Socrates and in operates, try and do them last. Why? I'll tell you. Because once you associate with relevant symptoms, if you find any that is present, maybe the patient will tell you, yes, they are coughing, they have chest pain. You have to Socrates that. So it looks very broken if you are Socratesing another thing, and then you want to go back and talk about the cough. So you finish with the cough, then you go to this new associated chest pain that you have to describe for how long, and you Socrates it. So after that, you look at the important positives and negatives. And how will you start? And okay, what are important positives and negatives? Important positives and negatives are a systemic inquiry that are relevant to the pathology you have in mind. By the time you're at number 2, you should know what the patient has to some extent. And now you want to ask some questions regarding those other systems that you suspect could help you rule out some things and rule in some other conditions. Because IMED is not about running to the diagnosis. It's about coming up with an extensive list of differentials and narrowing down to relevant differentials that will now be differentiated by tests. Some other differentials, you'll rule them out in history. Some you'll deal with them in tests. The most important positive or negative are your B symptoms. You have to start with those ones. You have to say, was there weight loss? Was there fever? And was there night sweats? And if there are, you have to quantify. If a patient tells you fever, you will probably be told in your infectious disease lectures how to assess for fever by Dr. Lois. She'll tell you how to assess for fever. You have to look at fever in terms of time of peak because there are types of fevers. There are malignant tertian. So you have to know these fevers. Do they peak? Is there weight loss? By how many kg? Or has the patient told you I can't fit into my clothes anymore? If there are night sweats, do I have to change my bed sheets? Because that speaks that this is drenching night sweats. Yeah. And you know why we are asking for this is because we are looking for TB, we are looking for malignancy, we are looking for some autoimmune conditions like sarcoidosis. So you see, like once you have weight loss, fever, night sweats, and you should know, by the in internal medicine, TB causes everything other than pregnancy. So you have to have that in mind, that TB is very important as a differential. So you have to know it, and you have to know how to rule it in and rule it out. So once again, I've said that important positives and negatives are like a relevant review of systems. And then risk factors are behavioral things and family social history that are relevant to your history. So once again, I've said maybe Njoro is a painter. Njoro has been painting for 20 years. Njoro now comes with some signs of maybe, let's take it to neuro. Njoro comes with some signs of encephalitis, or Njoro comes, he can't move the lower limb. You should know that up to 2009 in Kenya, a couple of the paints were still lead-based. Yeah? So lead, he could be having neurotoxicity or neuro symptoms based on lead accumulation in his systems. You should know also, although we've tried to reduce asbestos levels, they're still there. So you see Njoro in the rest pod, you have to be sure that maybe it's the paint that he has been inhaling, the paint chips that are causing this. Yeah. So you guys remember reading about kina mesothelioma and their friends. Very important things to now apply. Then now number 5 is a contact with the healthcare system. So you've talked about maybe you've ruled in, you've ruled out probable things that could be causing this presentation or things that could be associated with this presentation. You've talked about the risk factors, and in the risk factors, an important one is smoking and drinking history. So if they smoke, if they drink, mention it in your HPI. Don't talk about it elsewhere. You have to talk about it extensively in your HPI. You have to quantify the pack years for cigarettes. You have to quantify the units of alcohol. Then you talk about the contact with the healthcare system. So contact with the healthcare system means what? So number 1, it's an important risk. It's a blend between the risk factor and this number 5. You'll ask them, how many times have you experienced this symptom before? If they have, when, and you highlight those admissions, you highlight the interventions done at that point, because it could be speaking to something chronic. So now you've done the contact with the healthcare system. You've talked about that. Then now what else do you highlight? You'll highlight now, before coming to maybe Kenyatta, if the patient is a referral, by them, mention it in your biodata. I'll go back to that when you're reviewing it all together. So you will say the patient was rushed to Kenyatta where they since had an IV line put, drugs administered. They might not know the drugs, but if they'll tell you a painkiller, just say analgesics to sound professional, and fluids were given. And if there's any blood given, highlight how many pints. And then current status is how is the patient doing now. Number 6, some lecturers don't like it, but like Dr. Kosa doesn't like number 6. But number 6, just put it there. Symptoms have since subsided. If there's a new symptom, you can say patient maybe is not improving, because that could speak maybe something else. So once again, there are special conditions that really alter your history. I can't go into this now, but I'm just going to mention a bit on them. So there are things you have to do when you meet a patient with hypertension. Once again, with TB that I have said causes everything other than pregnancy, with HIV, with sickle cell, or a patient who has a malignancy. Actually, majority of the blood disorders, like the lymphoproliferative disorders that you've done, all of them, kind of try and think about them as you are looking into when you're clerking them, when you meet them in 1B, the patients in 1B, the patient who's living with HIV, the patient who had TB or has TB, the patient who's living with hypertension. Number one, you have to know anti-TBs, you have to know antihypertensives very well, and their side effects very well. You have to know. That one you have to know. There's no option. You have to know from the first one they give you to the others that they'll give you after that, to what are the probable combinations, to the complications of hypertension, which you should know, macrovascular, microvascular. Same to diabetes. I forgot what diabetes here, but diabetes as well alters your history because now you have to rule out their complications and you have to know their complications. So as you read, just look for the complications. What are the macrovascular complications of diabetes? Macrovascular complications of hypertension, microvascular complications of diabetes, microvascular complications of hypertension. What does TB cause? You know the forms of TB? There is primary TB, there's miliary TB, there's primary progressive TB. So you know, and you know the WHO staging of HIV. So you should know, and you should know that at which stage do people are exposed to getting, are at high risk of getting TB. So that's very important because they alter your history significantly. And you have to almost touch on every system in your history, knowing what you're looking for. So you have the past medical history. The important questions to ask in your past medical history are, is there any history of any previous surgeries? Any history of any previous admissions? And if so, which ones? Don't say patient has a previous history of admission. Because once again, when you're getting to past medical, the lecturer is kind of tired. Yeah. So now is when they're starting to lose focus. But then you can say something here that will really annoy them. And they'll look at you like, so the patient has a history of admissions. Which ones? You didn't ask. Patient will, the doctor consultant will ask the patient, how are you? How are you doing today? You admitted in hospital before? What was the reason? You find it's related to your presenting complaint. You don't have that. Your whole history has fallen apart. Yeah. You talk about any history of blood transfusions. So that is either receptive or did they donate? And if they received, how many pints and how long ago was this? Because you know the transfusion reactions, you know the complications of transfusion, from the ones that involve poorly screened blood to the ones that are immune mediated, to the non-immune ones, to the iron overload ones. So you know them. So it could be in the GI ward, maybe the guy received a lot of blood. There's been a patient like that before. Patient who's received a lot of blood. Then now the patient is presenting with liver symptoms like jaundice. Yeah. So now how you didn't highlight this in your history. Actually, if you find anything positive here that's related to your history, you have to bring it in your HPI again. Yeah. You ask for food or drug allergies. Very important. Patient could tell you, I had metronidazole. Now suddenly you have a patient with a rash and signs of kidney failure. Yeah. So they're having generalized body swellings with fatigue, coupled with fatigue or maybe vomiting. Yeah. And they tell you, I took metronidazole. So, you know, you're kind of thinking about that and they have a rash on their skin. So you see all those things are very important. Then you do something called thread. Thread is asking for these conditions: TB, hypertension, rheumatic heart disease, epilepsy, asthma, diabetes. And then when you're bringing it together, once again, try and avoid being point-oriented. Give it in continuous prose. And I'm going to emphasize on this. When you're presenting your history, it should flow from one level to the other, to the other, to the other. It's like you're speaking about this one patient. Senor. So these are the things that you'll highlight in your past medical history. Then you've hit your family social history. Family social history is not a history we take for fun, and it's not taken for fun. It has diagnostic relevance. Yeah. You remember when I said that the only difference between important positives and negatives and risk factors is that risk factors highlight behavior, while important positives and negatives are mini review of systems that are relevant to the presenting complaint. So let's say your patient is coming in with signs you're suspecting a pancreatic cancer, yeah? Then maybe body of pancreas or head of pancreas about. You're suspecting maybe a head of pancreas because that one we are aware of, because I remember in clinical chemistry something about that tumor head of pancreas. So you have tumor head of pancreas. Then you talk to the patient and you ask, is there any history of malignancy in your family? And then the patient tells you, yes, my mother have all been previously diagnosed with breast cancer. Very important. Or I have somebody I know with colon cancer. Very important, because we know they share receptors. So you should know that somebody with maybe a brain tumor, breast cancer, pancreatic cancer, colon cancer, these guys they are very related. So you have to ensure you ask within their family. So the number one thing is you'll ask about the patient's siblings. You'll ask how many were they born? Are they all okay? You have a patient with sickle cell and you've not done this, that's a crime. Actually, if you have a patient with sickle cell, you do this in your history, because you should be able to draw a pedigree. I know you guys have a genetics lesson tomorrow where you will be talking about pedigrees. While you talk about them, you'll understand. But you have somebody with sickle cell, you're presenting to Dr. Ilovi. You do not have a family history. Yeah. You do not have a pedigree. You don't want marks. That's the conclusion. She gives very good marks the moment you have that. So you have that, you have your pedigree, all that, you're presenting, and then the doctor could ask, passed on to breast cancer, pancreatic cancer, what are you thinking? You know the receptor relationship. They share important receptors. Then you ask if the patient's parents are around. So this thing is a very special question, because for my end of rotation, I had a patient who was 90, and I remember presenting and talking about the patient's parents, and Dr. Lois just told me, leave that, because obviously they're old. But then you have a young person, you could want to inquire, is there a history of this in their family? Especially in the renal ward. You're in the renal ward and you have not talked about, touched base on a bit of family history in a young person with hypertension, and you're not looking for autosomal dominant polycystic kidney disease, that's a crime. So you're leaving free marks there. You talk about it, they say, this one knows what they're talking about. So if the patient has children, how are they doing? Are they all okay? If they have a medical condition, highlight it. If it's hereditary, look into it. Yeah. Is the patient married, wife or spouse? I forgot. Sorry. I'll remove the ambiguity. I'll put it as spouse. So do they have a spouse? What's the relationship with their spouse? This is building a humanistic picture, and Dr. Euro likes this. Build a humanistic picture. Paint the patient as more than a condition, but as a living being. So you talk about the spouse, their relationship. Are they estranged? If they are, talk about it, yeah? And the patient, how do they live? So if they live in this house, talk about ventilation, talk about how they cook, talk about their trash, because you're going to do these things in Com Health and they have medical relevance. So their trash, how is it collected? Is it regularly collected? Their water, where do they get it from? So you know hard water, or all the things that could come along with hard water, or water from uh, places that are not treated. So you should know about that. You should know about the ventilation in their house. You should know about maybe even the toilet situation. If you are in GI, you have a patient with diarrhea and you've not talked about this in your history, it's a bit shows that you are not bringing things together, and you have to link them together. So how does the patient live is very important. And then you ask about NHIF, or how do they plan to pay? If the NHIF are insured, don't leave it at that. Dr. Euro, they like you humanizing the patient. So the patient is NHIF uninsured, they plan to pay with cash, or they have reached out to the welfare society hapo at Kenyatta. They normally go to second floor. If you're a Muslim, you'll talk to the imam who's normally there. If you're a Christian, Catholic, or Protestant, there are the reverends there who normally issue a site visit, and they'll kind of look into your situation. And if you can forgo the payment, they end up working the grounds or working in the catering department. So it's very important because it humanizes the patient. Once again, the patient is not a condition, the patient is more than that. So then you go to review of systems. The review of systems is very important, because in the review of systems, you are doing it systematically. So for your whatever, number one, don't repeat what you've done in your history, in your important negatives here. If you've touched base on that, leave it. If you have not reviewed your systems because you have a patient with hypertension and there's no review of systems in that, then you will quickly touch on CNS. You'll ask, have they had a headache? Have they felt dizzy? Have they lost consciousness? Had a ringing in their ear? any feeling like they are the ones spinning. Vertigo and dizziness have a difference. This is your assignment. Go and read on the difference. And it's very important because they speak to two different conditions. And then you ask for any changes in the five senses. So any unusual tastes, smells, anything different in hearing. Have they had changes in their vision? Things like that. For cardio CVS, you'll ask about the chest pain, palpitations, tachycardia, diaphoresis means increased sweating. Very important, by the way. For the rest, we'll ask about the cough, chest pain. For the skin, what I call the integumentary system, lumps or bumps. So, and you have to know how to describe the skin rashes, by the way, because some of them are very important. You might go to the ward. I don't know if this patient is still around in 6B. There's a patient who has a very unique condition, Sjogren. So if they're still around, you should know that they also have some skin manifestations that you have to look into. Or you're in the rest pod, you have a patient with asthma, and you know there's a relationship between eczema and asthma. So you have to look into that. Musculoskeletal, be sure to ask about joint aches, joint pains, or any joint swellings. I forgot to write renal here. Renal, obviously, inquire about oliguria, anuria, dysuria, inquire about any body swellings. Those are the important things while you're looking, and any change in the urine color. So that's the two questions. Is either change in urine color, change in urine frequency, or change in how they pass urine. So those are the important questions you have to ask. So in general, how will your history look like? You have the biodata, you have your presenting complaint that we've talked about, you have your history of presenting illness, you have your past medical history, you have your family social history, review of systems, then you give a summary. Yeah. So how will you summarize your history? Summary of a history requires you now, when you're taking the HPI, this is a lesson I wish I was told earlier on. I learned it quite close to end of year, actually. But when you're giving a summary of your patient, it's a very easy thing. In summary, you apply bias. In your HPI, you don't apply bias. But in your summary, you apply a bias. So by the time you've done all this, you probably know this guy has TB. Yeah. So patient, so in summary, I'm presenting 1, 2, 3. So it should be 2 to 3. At a 2 to 3, you're reaching, but it should be 2 to 3 sentences. Yeah. So you give your 2 to 3 sentences, and that will have number one, the patient's name, the relevant biodata, presenting complaint, and then an important positive that is telling. So if they had weight loss and night sweats, yeah, you talk about them, and then a behavior that has led you to that patient has a history of maybe contact with somebody with similar symptoms. Yeah. So that is your summary. Short thing with bias applied. Yeah. Because you're giving what you think is your impression and what the patient has. And then you do a general examination. So after you do a general examination, I believe because of PIDS, you have an idea, but once again, this is IMED, this is not PIDS. So you should have an idea, general idea on how to do a general examination. And once you do a general examination, you summarize your findings. So how will you summarize your findings? I conducted a general examination on Nathan Rono, 23-year-old man, and the following were my findings. So the patient was saturating at maybe 98%, had a pulse rate of 72 beats per minute. Patient had no jaundice, no pallor, no peripheral or central pallor, no cyanosis, no finger clubbing or toe clubbing, no lymphadenopathy, no signs of edema, and no signs of dehydration were noted on the general examination. And then you'll do a systemic exam. You do all the systems, but your primary focus should be on the system most relevant to the patient's presenting complaint. So if they came in with the RESP symptoms, you will start with your RESP exam, which you will do, and you will summarize your findings. And then you will do a CVS exam. Then you will do maybe if they had a neuro somewhere, you do a neuro exam, then you do a GI exam. Always finish with the least relevant to the presenting complaint. And then you've summarized all of them at the level you're doing them, you're done. How do you put it together? Once again, I've said don't turn it into a point first. Don't start giving the lecturer points in a point manner. Do it in continuous prose. Don't be timid. Number one, don't be timid. They really hate that. They have absolutely no time, interest, or inclination to listen to whatever you're talking about. So if you're making them to strain, well, they already feel like they shouldn't be there, you have failed for sure. So don't make them strain. Talk like you've never talked before. Be articulate. Address what you want to address in continuous prose. It's like you're giving an essay. Yeah, you're giving a biography of the patient. So you're given your biography that is a medical biography, and you're done with that. And then while you're doing your history, if there's one thing lecturers hate, it's fishing for information that makes no sense, that is not relevant. You're just asking to cast a net such that iko muuliza, you've asked everything. Something they really hate. If a lecturer stops you smack in the middle of your history and they ask you, maybe Omondi, why did you ask that? Because that's a common question you'll get. In your end of rotation as you present, I got it several times. You're presenting, so why did you ask that? You explain yourself, you give your reasoning, it makes sense. They get impressed. If it doesn't, it's a dangerous sign. They know you're fishing for information, yeah? So you ask educated questions, you don't fish. And then number 4, I've told you past medical and family social history is so important. You cannot ignore going into the specifics of them because some diseases will leave you baffled with their presenting complaints. They could have everything, but then maybe you have just inquired a bit into their family social. So I had a patient, 7A nephrology. This guy comes in, 25-year-old with hypertension, very odd thing. Then patient reports also feeling a mass on the flank, yeah? So I'm like, okay, could be renal cell carcinoma, yeah? So I'm asking, patient doesn't smoke, biggest risk factor for renal cell carcinoma. And then patient tells me they don't smoke. And then now I'm a bit baffled. You quickly ask the question. So anyone in your family with this quickly tells you that my sister turned 18 the other day. She presented with hypertension as well. Then it clicks. Yeah, this is autosomal dominant polycystic kidney disease. So you have to really be keen on those facts. Past medical, you're talking with this guy, you're getting nowhere. Especially you go to the ward, some of those patients have been there for too long. They have too many things going on. So you ask them, have you been admitted for this before? You find a guy who will tell you, I've had TB, but I didn't finish my medication. And then everything makes sense. So it's very important to be keen and not ignore the importance of a good past medical history and a good family social history. So just a closing word of wisdom, I think. See if yeah, it's a closing word of wisdom. When you go to the wards, going to the wards and then going back to read is an interesting thing. Try and read before going to the ward. Says you probably have been oriented onto where to go, what to do. Yeah, so you have the general layout, the plan. So now start reading. You read before you go to the wards. You use the resources that you have made available by the university, like Ambos. Ambos is there. Then you use your Hutchison textbook. As I've said, Hutchison is a book that you have to know how to use it. Yeah, because Davidson's or Kumar and Clark are where, and Ambos are where you get the content. Hutchison tells you how to bring that content that you've gotten from these resources into the words. Because Hutchison will tell you how to take a good history. And once again, as I said, most of the presenting complaints are highlighted in Hutchison's. So now you have the highlighted presenting complaints. They have given you how to take a history and how to put it all together, how it is relevant diagnostically, what to note of its relevance, what not to note. So you have the idea from Hutchison's. Then the next thing you need to do is you need to plan your time accordingly. You have to really lock in because it's very easy to go to the wards and just walk around with your lab coats looking all cute. But then you go home as a guy, you've taken snaps, you've enjoyed the scenery. but you've not done anything that is going to add value to your grades. So you go to the wards, you waste time, and you go home and you're like, what have I done? And there's nothing you've done. So you need to plan your time. You need to know, if I'm going to clerk, if I'm going to the wards, I'm going to collect X amount of signatures, I'm going to do this and this and this, and then I'm going to go. Then number three, you have to have effective group discussions. I cannot belabor on this. Group discussions are very important. Nate is here. He can tell you more about it, because he's really adept in organizing groups. And you shouldn't be afraid to ask for help from your friends, people who know. Just always ask. And then the next thing you have to do is to present, present, and present. A history not presented is a history wasted. Don't be afraid of shy, because at the end of the 11 weeks, it doesn't matter if you're an introvert, you will face your accuser in the internal medicine department, and it could be really well, because it's easy to tell if somebody hasn't been going to the wards based on the history, or if somebody is just new, that was their first time in the wards. So just something in closing, fortune favors the bold. So take action. It's your education. You pay a lot of money for it. So make use of it. I think that's it. I'm done. Nate, are there any questions?
Thank you. I've tried answering most of them in the chat. Maybe one thing to mention is we forgot the obs and gyn history, in case it's a lady. So I've told them you do the obs and gyn history before the family social history. And then someone has asked, could you explain what are important positives and negatives? Can you give an example? So maybe you can address that.
Okay, I don't know, Nathan. Should I access a certain document in order for it to be more practical? Because I can't start cooking stuff at the top of my head.
Sure.
Sasa, let me open the document and then maybe we can start from there. The past 7 years, prior to which she was residing in Limuru, where she stayed for 20 years, and in Kakamega, where she stayed for 22 years. She's a casual laborer by occupation and was admitted 9 days ago. She's a non-hypertensive, and she was diagnosed 2 years ago at a health facility in Syokimau. She has been on enalapril and is non-adherent due to financial constraints. The patient came in presenting with a 2-week history of chest pain, a 2-week history of a cough, and a 1-day history of difficulty in breathing. So that's the general presenting complaint, yeah? So now I have Socrates and operates the pain and the cough. The cough, by the way, it's related to the enalapril. So the difficulty in breathing, I've done that because this is somebody who's gone into acute decompensated heart failure. So now we're going to look at these things. So maybe I'll start from where the patient reports a 1-day history of dizziness. Once again, this is an important association. So a patient reports a 1-day history of dizziness, which she describes as feeling as though the room is spinning, and a headache that was located on the occiput of her head and that was sudden in onset. She describes it as throbbing in character and had no exacerbating or relieving factors. It was non-radiating, and she graded it as a 6 to 8, between 6 to 8 on a scale of 0 to 10 in severity. And the patient reports that for the past 3 months, her vision has been progressively deteriorating. This is an important association, a relevant association, and can no longer read her phone when it is held 30 centimeters from her without increasing the front of brightness. This is an important thing in hypertensives. So the patient reports no loss of consciousness, weakness, or double vision. So if you notice, I've done everything, but then now I'm asking myself, what else could occur in this patient who came in with dizziness? So I've asked about loss of consciousness, weakness, or double vision. I was ruling out a pituitary tumor, probably ACTH secreting, and subarachnoid hemorrhage has also been ruled out. So she reports no hematuria, dysuria, oliguria, or anuria. Renal failure has been ruled out. Patient reports heat tolerance that began 2 years ago. Initially, she used heat intolerance that began 2 years ago. Initially, she used to shower with hot water, but now keeps her showers lukewarm. So there, it's probably menopause or thyroid, or a thyroid condition that was trying to rule in. She reports difficulty in inducing and maintaining sleep for the past 2 years. We know that melatonin fluctuates with either an issue if the patient has approached menopause or if the patient has a thyroid condition. The patient has no history of recreational drug use. So recreational drug use, this one now I'm in risk factors. So recreational drug use, I asked about alcohol, smoking, IV drug use, cat, and cocaine. So it's input. These ones are now risk factors. So if you notice, important positives and important negatives are kind of inquiring when it comes to the systems, because we have a patient with chest pain, with cough, with difficulty in breathing that is here. So now, once I delved deep, I discovered that this could be a cardiac thing. Yeah, because I ruled out the chest pain was not related, had no association with any pain in the joints, had no association with changes in swallowing, with no dyspepsia. So I was doing relevant associations, trying to bring them in. And then now, once I had an idea that the issue with this is the heart, I tried to ask myself, is there anything else that can occur as a result of what caused her heart to fail? Or is there anything else in her system that caused the heart to fail? Yeah, or are there any systems uh, that have taken a hit from a heart failure? So it's like a review of systems, but within your history that is relevant to the condition you're trying to look into. That's the best way to describe it. I don't know if I've answered your question properly. This is a very important question that has been asked. So presenting complaint is in patient's own words, but once again, try and when you have a patient, I'm going to give you words, nuggets of wisdom here that I learned the hard way. Let the patient talk uninterrupted for 10 minutes. Let the patient tell you their story. Then you'll be able to come up with a coherent presenting complaint. Because once again, there are some words, there are some feelings that patient will go through that doesn't have a word in English, and they could tell you in Swahili, they could tell you in their mother tongue. Uh, and you have to be able to listen and really pick out what is this. So now when you go to the HPI is the backbone of the medical interview. I've just seen the question. So the HPI shows it's the interface between you who has excessive knowledge of medicine, translating what the patient is saying into medicine. So you organize it, you try and keep the jargon away, but you also use it when relevant. You see how I brought it out when I said about dyspnea. I said the patient reports, initially the patient reports difficulty in breathing on exertion, suggestive of NYHA grade 2 dyspnea, because that is the grading for dyspnea in heart failure, it's NYHA. And then, however, 2 days later, patient reports that experiencing difficulty in breathing, even at rest, suggestive of NYHA grade 4 dyspnea. So that's how you bring it out. You bring it out subtly you connect it with words like suggestive, so that it shows that you're not confirming anything. This is an interesting question. What examples of open-ended questions can you ask that has the potential to entice the patient to speak for 10 minutes non-stop? Just tell this guy, you walk up to the patient's bed. Number one, an important thing you're going to learn, shake the patient's hand, say, hey, this is what I'm here. My name is, avoid mentioning you're a student. They'll never talk to you once you say that. Just try and say, I'll be in your ward this week. And so you listen to the patient. The patient will probably tell you their story. They'll start being apprehensive, but once they start yapping, they won't stop yapping, trust me. I hope that answers you. You just ask them how they are doing and how have they been and what brought them to hospital. The moment you do that, you've established rapport, you've let them speak, believe me, they'll talk. So I hope I've answered your question. Okay, you're welcome. Are there any other questions? Were born out of a group discussion that we had. Okay, so there's a key question here before I continue on what would you do if the patient changes the story when the consultant comes. Number one, I've not encountered I've encountered an apprehensive patient, but remember once again, these guys are going through, their disease is not a case for them. It's easy for you to detach, go home, eat, move on with life, but this guy is facing life and death there in the wards. Yeah. So you have to be cognizant of that fact. So in order for you to prevent this thing from happening, you have to show them that you are more than a study object to me. You are somebody who matters. So that in that way, when you listen to them talk for 10 minutes, nobody can maintain a lie for that long, especially a medical lie. You can't maintain it for that long. If you give them a chance to talk, you will quickly point out if they are spewing lies and how to edit it before the consultant comes. I hope that makes sense. Because you establish a rapport, you acknowledge the fact that they are sick, you are well, and you have to know that they are going through something. So you are aware of that and you approach them with the finesse necessary. Right. So just a small introduction as we close, because I'm seeing there are no other questions. We were born out of a group discussion we had that helped us sail through our IMED rotation. A couple of our members are here. I can see Kate is here, Nathan is here, and myself. So how we had this discussion and we were able to put our histories together to talk. And now we had an idea of starting tutorials on internal medicine, where we'll give hybrid lectures, making ourselves available in the wards and on online platforms like Zoom and all that. We have a different Zoom. We won't be using your class Zoom. We have our own on standby. And we'll be giving hybrid sessions as well as physical sessions on examination techniques and all that. It's a very comprehensive thing. If you're interested, you can contact Nate, myself. I think Keith is here, but Nate might be an easy liaison because I can see he's in your groups. So you can easily reach out to Nate if you're interested, because for that, once again, as I've said, history taking is an art that really varies with the system that you're approaching. So we sent out a form and we saw that there are 20 people who signed up, and those 20 people will be adding them to a group this evening. And we will take you through and try and shortcut you through the internal medicine rotation and how you can survive based on every system. And we'll be providing, once again, hybrid tutorials, both physically and online. We'll make ourselves available at the wards and times that are comfortable with you and us as well. So yeah, I think that's about it. Nathan, anything else to add?
So thank you so much. It was a very great session. I hope you guys have learned a lot. That's a lot of things you've done in, I think, 1 hour. So I'll make this recording available. Your class rep has requested that I send to your Telegram group. I will. I'll also upload it on YouTube so that you can rewatch it anytime you feel like. Yes, so if you have any question, you feel free to contact me. I've left my number on the WhatsApp group. Sorry, on the Zoom chat. Yes, I think that's all I have. Maybe Keith, if you have something to say. Where have a discussion group where one member is in one ward. For example, I'm in the GI ward, RESP ward, CVS ward, hematonco ward, so that you can consolidate your knowledge. So, because different lecturers want different things, and you'll have to know that. So if I'm in the GI ward and my lecturer wants this, so I'll tell you during the discussion, present to each other, critique each other. It really, really helps. Yes, I think that's all I can say. There's one more question. Someone has asked me, is it advisable to take notes as the patients tell their history, or just listen, then write down the history later? So one thing is, during your exam, you'll have exactly 1 hour to clerk the patient and to do your exam. So if you do that, the 1 hour will not be enough. And trust me, the 1 hour is not enough. So as the patient speaks, as Sean said, give them some time to speak. Don't interrupt them. That is when you're taking your notes. If you have this schematic of how to take a history, the 6 points Sean has said, while the patient is speaking, you'll be filling in, okay, saying this, okay, shortness of breath, it started like this, and this. So you can maybe stop him and ask him, because some patients actually deviate from their stories because they have a lot of things in their mind. So you can tell them, excuse me, please, can you answer the questions that I'm telling you, do this and this and this, and be specific on your questions if you see them that they're deviating. So you can just write while they speak, because the 1 hour is not enough. How we used to focus our time was you do 30 minutes exam, 30 minutes, you clerk for 30 minutes, then you examine the patient in 30 minutes. So yeah, but as of now, since you've started, just practice history taking, and then exam techniques will come as, you know, as you get to maybe week 6, week 7. So right now, take as many histories as possible. Focus on your ward, first of all. Some people tend to ignore their wards as much as, yes, during the end of rotation, you not go to your ward. During the end of year, you can go to your ward. It's a very high possibility because it's very random. So focus on your ward for like 1.5 weeks or 2 weeks. Know everything that's in your ward, attend the ward rounds to know the cases and familiarize yourself. Then after that, you can now start going to other wards. Yes.